Eva was a 16-year-old young lady enjoying the afternoon playing golf with her grandfather. Suddenly, she wasn't able to pick up the club in her right hand as she was going for her next shot. She became confused and, according to her grandfather, sat down without speaking. Her grandfather called 911 and she was rushed to the hospital. The doctors examined her and did some preliminary tests and discovered that Eva was having a stroke. Ladies and gentlemen, my name is Shahid Nimjee, and I'm a vascular neurosurgeon who specializes in taking care of patients who suffer strokes. Many of you in this room are probably familiar with what a stroke is. A blockage in a blood vessel that prevents blood from reaching the brain, depriving it of oxygen, resulting in injury and possible death. But what you may not know is that stroke is the single largest cause of combined morbidity and mortality in the world today. In the United States alone, a stroke occurs every 40 seconds, and every 4 minutes, somebody dies of a stroke. 1 in 4 people in this room will have a stroke in their lifetime. Of the 800,000 people who suffer a stroke every year, almost 30% of those people are under the age of 65. Unfortunately, my patient Eva was one of those 30%. After the neurologist completed her assessment on Eva, she administered TPA in hopes of improving her condition. TPA is a clot-busting drug given to patients who develop an acute stroke due to a blockage in a brain vessel. Unfortunately, this drug can only be given when the stroke has occurred within the last 4.5 hours, because at that point, the risk exceeds the benefit of the drug. What is that risk? Bleeding into the brain, which occurs in 6 to 7% of patients who receive TPA, and when it does occur, results in patients dying from that bleed in almost 40% of the cases. This limitation of TPA results in its use in only approximately 10% of patients who present with acute ischemic stroke. Imagine, 800,000 patients suffer a stroke in the United States every year, and the sole pharmacological treatment available can only be used in 10% of cases. After starting TPA on Eva, the neurologist immediately called me and said that imaging studies of the blood vessels of her brain showed that she had a blockage in her middle cerebral artery at the base of her brain. This middle cerebral artery on the left side of the brain is responsible for all function on the right-hand side of the body, as well as the ability to talk. Eva was paralyzed on the right side of her body, and she could not speak. She had received TPA, which in her situation only had a 10% chance of working, given that she had what we knew to be a large vessel occlusion stroke. I rushed Eva to the operating room in order to remove the clot. To remove the clot from her brain, I put a small tubing or catheter into the femoral artery, up the aorta, which is the main arterial pipe of the body, made a left into the carotid artery, made another left into the middle cerebral artery, and I pulled out the clot. Now I know what you're thinking. What I just described sounded something like out of Grand Theft Auto rather than a surgical therapy. The moral of this story is, if you want your kid to become a neurosurgeon, let them play video games. It's that easy. I did this procedure while Eva was awake, and when I was finished, I told Eva, "I'm done." To my surprise, she responded, "Thank you." Today, Eva has returned to playing golf with her grandfather and attends Ohio University on an academic scholarship. This groundbreaking treatment, a thrombectomy, was the first step forward in stroke therapy in 20 years and allowed us to provide an option to help patients where previously there was none. Unfortunately, this therapy too is only effective in patients that have large vessel occlusion stroke or a clot at the base of their brain, which is by far the minority of patients today. If we combine all the patients who receive either TPA and or mechanical thrombectomy from someone like me, it only accounts for 20 to 25% of all patients who present with a stroke, a disease that affects almost 1 million people every year and only be able to treat 20 to 25%. It is both frustrating and motivating. In addition to being a vascular neurosurgeon, I'm also a translational research scientist focusing on developing treatments to improve outcomes in patients who suffer from stroke. A translational scientist is one who takes ideas from the bench, bring it to the bedside to help patients. However, being on the front lines, fighting this disease, I have learned that the best way to find treatments and cures is to start with the patient, then go back to the bench before returning to the bedside with treatment in hand. Being a clinician allows me particular insight into the nuances of the disease, and my research background in molecular genetics and translational research enables me to use the tools of science to develop new therapies. Our leading therapy in stroke focuses on two important aspects of treatment. One, that it actually targets the clot that is involved in the stroke. And two, that we have a safety mechanism in place that should there be any untoward bleeding, we have the ability to turn the drug off immediately and take that patient to the operating room to perform life-saving surgery. Analyzing the clots from patients who have undergone a mechanical thrombectomy has shown that a particular protein is present in the majority of these clots called von Willebrand factor. Von Willebrand factor is critically important in forming a clot, stabilizing that clot, and propagating that clot. We have developed a drug that inhibits von Willebrand factor. We have also developed a second drug that turns the first drug off within minutes, thereby creating an on-off switch in drug therapy. Our preclinical models of stroke, developed here at the Ohio State University Medical Center and carried out here, demonstrates that the drug improves revascularization in the brain and reduces the amount of stroke or infarct seen on MRI. I'm thrilled to report that we will be starting phase 1 clinical trials this fall. The success of this drug would mean the chance of someone like Eva doing well after a stroke becomes the majority of the cases and not the minority of the cases. And given that 80% of patients currently have no treatment options, not only will those patients now have a chance at life, but a fully functioning life. The work I've described has taken me and my team the better part of 15 years to develop. The most important part of this is that we're here, and we continue to move forward. As I look forward to opportunities in stroke research, I look at developing agents that will reduce brain swelling from stroke and even use gene therapy to allow previously non-functioning brain to function again. These are my plans for the next 25 years. I invite you to come join me.